Welcome to the Radiology Vault, an open repository for radiology educational content designed for learners and medical professionals. Presented by the Michigan Medicine Department of Radiology.
Hello, my name is David Bloom, and I am a pediatric radiologist at CS Mott Children's Hospital in Ann Arbor, Michigan. And it is my pleasure to speak to you today about a topic I find very interesting, sometimes confusing and stress-inducing, but I think we can make it as easy as possible for all of you, and that is neonatal distal bowel obstruction. I do not have any disclosures. Moving on to meconium ileus. It is important to note that there is an association with cystic fibrosis, such that approximately 20% of patients with cystic fibrosis will first present with meconium ileus. That is how they are diagnosed. And conversely, over 90% of patients with meconium ileus will therefore turn out to have cystic fibrosis. So keep in mind this association. Now, the obstruction that we see, the distal bowel obstruction, is related to the thick, tenacious meconium that is packed within the terminal and distal ileum, leading to a microcolon and distal bowel obstruction. On abdominal radiographs, you will sometimes see bubbly opacities in the right lower quadrant. That is the meconium that you're seeing. And they say that there should be a relative lack of air fluid levels on a horizontal beam radiograph. We perform the contrast enema similar to how we would do a study for Hirschsprung disease. And what you will see is a microcolon, and when you reflux the terminal and distal ileum, filling defects that are the packed, thick meconium in the distal small bowel. They say that in meconium ileus, you will have the most micro of microcolons. Now, a microcolon is usually one where the diameter is less than or equal to the height of a vertebral body. Now, in meconium ileus, approximately 50% of those patients will be complicated by an associated bowel atresia or stenosis, a small bowel volvulus, not related to the midgut, but related to the obstruction, or perforation with a meconium pseudocyst. The contrast enema will be and can be both diagnostic and therapeutic. We start with a diagnostic enema, and as we mentioned, we're using water-soluble contrast. But with water-soluble contrast that is relatively higher in osmolality than plasma, this allows water to be drawn into the bowel lumen, helping to loosen up the meconium and hopefully treat the obstruction. Now, we would often use contrast material that is slightly hyperosmolar, but radiodense, so that we can perform the diagnostic study first. It will start the therapeutic process, and then you can use slightly higher osmolar contrast material agents to subsequently perform the therapeutic enemas, which today we're only talking about the diagnostic studies, but there are therapeutic options in patients with meconium ileus using the contrast enema. So in this particular patient, we again have a lot of dilated loops of bowel. We can see it's a newborn with an umbilical venous catheter and other support lines, including an umbilical arterial catheter. On the subsequent contrast enema, there is an artifact with contrast in the diaper, but we see a very, very small colon, a microcolon. Look at the size of the colon and its diameter relative to the vertebral bodies. And we are now refluxing the terminal ileum, which is within the right side of the abdomen, and it is filled with multiple filling defects. That is the thick, tenacious meconium of meconium ileus. So a nice example of meconium ileus on a contrast enema. Now, keep in mind, we have not refluxed the contrast into the dilated air-filled loops of bowel on the radiograph. So we may have a complicated meconium ileus, and it is worth trying to reflux back into the dilated loops if possible, but doing so safely. Another example of a distal bowel obstruction on the neonatal abdominal radiographs. In this particular case, we do have air fluid levels, so we don't always follow the rule of lack of air fluid levels and possible meconium ileus. In this case, the arrow is pointing to the reflux terminal ileum, which has multiple filling defects, the thick meconium, and again, we see a microcolon. So another classic appearance for meconium ileus. Now, I would also like to point out that the rectum is a little more distensible than the remainder of the colon. We had mentioned earlier that when you have a microcolon, total colonic Hirschsprung disease is a possibility. If that were the case, then the rectum would be the same caliber as the remainder of the colon, because it is also aganglionic, and we would not have the filling defects in the terminal ileum. In fact, with total colonic Hirschsprung disease, you often have easy reflux of contrast into the small bowel, including into the dilated loops, and a foreshortened colon. So not only a microcolon, but it'll be foreshortened such that it will sometimes look like a question mark. In this particular patient with meconium ileus, you see contrast within the upper gastrointestinal tract. It is faint, and that was related to a previous upper GI performed for potential bilious vomiting. Again, another example of how a distal bowel obstruction can lead to bilious emesis. Moving on to meconium plug syndrome, it is a functional immaturity of the colon. It is also referred to as the small left colon syndrome. I like that name simply because it describes what you're going to see. Now, the risk factors for meconium plug syndrome or the small left colon syndrome include infants of diabetic mothers, if there had been magnesium sulfate administration during pregnancy, and prematurity. Now, we already mentioned that in premature infants, Hirschsprung disease is relatively uncommon. We do see the meconium plug syndrome in association with prematurity. It's that functional immaturity that we were talking about. You should have a normal caliber rectum and a small descending colon. The transition zone that you believe you see is almost always in the region of the splenic flexure. Like other obstructions, there can be meconium plugs. That's where it also gets its name. And the contrast enema, like meconium ileus, can be or should be therapeutic. In other words, the patient will have an evacuation after the procedure and the bowel obstruction will improve. Now, if you do the contrast enema and you think it's small left colon syndrome, but the patient shows no improvement, it is often recommended that you should do a suction rectal biopsy to make sure that you're not missing Hirschsprung disease. That is in the differential. In this example, we have a patient who has a distal bowel obstruction with multiple dilated air-filled loops of bowel. On the right, the contrast enema shows us a classic appearance for the meconium plug syndrome or small left colon syndrome. Note that the rectum is more distensible than the sigmoid colon and descending colon. The remainder of the colon from the splenic flexure proximal is normal in caliber to slightly distended. Now, we mentioned that the differential, not taking into account history, would be Hirschsprung disease. If this were Hirschsprung disease, we would expect that the rectum would be the same caliber as the remainder of the small left colon. Also, most cases of Hirschsprung disease, approximately 80 to 85%, will have their transition zones, both radiographic and at surgery, in the rectosigmoid. In this particular case, we'd be placing the transition zone at the splenic flexure. So since that would be less likely for Hirschsprung disease, since most will be more distal in terms of a transition zone, seeing also that the rectum is more distensible, this would be a nice example and a diagnosis of small left colon syndrome. Again, using the history to help us. Here are some more examples of small left colon syndrome. Again, the transition at the level of the splenic flexure related to the functional immaturity and a more distensible rectum in this particular series of patients. Now, one other thing that I'd like to point out is that I have seen patients who have had functional immaturity of the colon that in very premature patients, they actually will have more of what looks like a microcolon, thinking about different diagnostic possibilities. And on subsequent enemas, they then look more like a small left colon and then a normal contrast enema, such that you're watching the development of the colon over time. So keep in mind that in very, very premature infants, you may even see a more proximal small colon, even a microcolon. Finally, ileolatresia. Now, it is believed that embryologically this is related to an in utero vascular accident that leads to injury to the bowel and an atresia that forms. It is associated with potential, because it's a vascular accident, with potential perforation and therefore pseudocyst formation, meconium peritonitis, and there can be other small bowel atresias. As I mentioned earlier, the patient with jejunal atresia, distal ileoatresia, and multiple atresias in between. In ileoatresia, you also have a microcolon, and you will be unable to reflux the terminal or distal ileum. You might reflux some portion of the terminal and distal ileum. It will not be packed full of meconium, and the contrast column will abruptly stop at the point of the atresia. So in this particular patient, we see a microcolon. We eventually reflux the small bowel, and we can follow those loops of small bowel from the right lower quadrant to the mid-abdomen. And then there is a rounded, sort of slightly bulbous appearance to the end of the small bowel where it abruptly stops. The contrast column stops. We see more dilated air-filled bowel above this. There is no meconium-packed terminal and distal ileum, and this is an example of ileolatresia. In other cases of ileolatresia, you might actually reflux only a very short segment of terminal ileum and then have that same abrupt stop or cutoff of the contrast column. Again, without the packed meconium in the terminal ileum, you would favor a diagnosis of ileolatresia. In conclusion, it's the clinical history and recent abdominal radiographs that will help determine a high versus low or upper versus lower neonatal bowel obstruction. And today we talked about the neonatal distal or low bowel obstruction. The four primary diagnoses for the distal neonatal bowel obstruction are Hirschsprung disease, meconium plug syndrome or the small F colon syndrome, meconium ileus, and ileolatresia. Most of the time, it will be one of these diagnoses that you will be able to make by using the appropriate radiographs and contrast enema. As an aside, when doing neonatal fluoroscopy, keep in mind that it's important to have appropriate support staff with you and to make sure that the environment is conducive for the patient, specifically multiple blankets and warming apparatus, since the neonate is not homeothermic to a complete extent in the neonatal period. And again, here are my references, and I thank you for your attention.